Welcome to Dementia Dialogue. Stories bring us together and help us to understand one another. Our podcast gives people with lived experience of dementia a way to share their stories with each other and the broader community in order to increase understanding and connection and decrease stigma. In this episode of Dementia Dialogue, we have a conversation with Dr. Shabbir Amanullah, Divisional Chair and Clinical Director of Geriatric Psychiatry at Queen's University and Kingston Health Sciences Center, and Jillian McConnell, guest host and knowledge translation specialist with brainXchange. Today, Dr. Amanullah and Jillian discuss sleep and dementia, how one affects the other, and what we can do to improve sleep and our overall cognitive well-being. Let's get started. So welcome, Dr. Amanullah. Thank you so much for joining us today. We're going to jump right into the questions. So my first question has to do with just sleep and brain health. So how does poor sleep affect brain health over time?
Thank you very much for inviting me to be part of what is really a very nice platform for information exchange. And in this day and age with so much of false information, wrong information, misleading information, it's good to have a platform that is able to disseminate factual information, evidence-based information, and also the ability to link various people from different academic centers, clinical centers, to bring this information to patients. Sleep, as you know, is probably one of the single most complicated aspects of human functioning. And the reason I use the word functioning is you become dysfunctional if you can't sleep. So if you define health as overall well-being, the absence of good quality sleep can result in significant health issues. So why is it that we have this big area that appears to be so nebulous with not often very effective interventions? Is because it affects so many different aspects of health. So if you take health, for example, take brain health, and you do brainXchange. If you take brain health to be one small part of the impact that lack of sleep can have, you're looking at the brain in of itself affecting other aspects of our functioning. So imagine if you have a problem to do with fatigue and exhaustion because you're not getting proper sleep. From a physical point of view, the impact that has on other body systems as well. So it's not just an isolated area. Each of these parts that are affected will have a profound impact on the human body as a whole, but definitely the human mind. So yes, it does affect in various ways. And it's not just the lack of sleep. Sometimes it's excessive sleep as well.
It's an interesting note. Thank you for that. So given what you've just said, and that makes complete sense, can improving sleep quality help prevent dementia?
Dementia is multifactorial. It includes aspects of dementia which we are still beginning to unravel, which includes things like genetics. So for example, is a particular form of dementia inheritable? Well, we do know that there are certain gene pools that actually show that there potentially is, but we still don't know very specific aspects of it. So when you talk about preventing dementia, sleep is just one small part of it. So maybe it helps in the larger picture. So for example, you talk about things like epigenetics. Epigenetics is the impact that the environment has on how the genes manifest some of the proteins that it produces. So it may never produce that protein if you didn't have a particular trigger. Now, can the trigger be environmental? Yes, because that's what's the impact of epigenetics is about what the impact environment has on how the genes manifest these proteins or how they produce certain agents. So if you look at improving sleep and then preventing certain genes from producing certain types of protein, yes, it's very likely that a good quality of sleep would prevent the gene from being triggered into producing abnormal proteins. True. But it's also true that you can sleep all you want and probably sleep too much. And then you have a higher risk of other conditions that potentially you wouldn't have had if you had good quality sleep. So good quality sleep is a balance between adequate sleep rather than just excessive or inadequate sleep. Same thing with the diets that we have. You can eat a lot, right? So for example, multivitamins is good for health. So am I going to take a ton of multivitamins because it's good for health? No, you're going to end up with trouble. So some people try to overcompensate. Because I didn't sleep during the night, I'm going to sleep during the day, which again is a problem. So can good quality sleep prevent dementia? Maybe not prevent dementia if you already have significant other factors playing a part, like unhealthy eating habits, alcoholism. So it may not change. But if you can do it as part of a holistic lifestyle change, it could help delay the onset, yes.
So conversely, can we talk about a little bit about how dementia impacts sleep patterns and qualities?
Mm-hmm. So when we talk about dementia, we need to talk about aging and sleep patterns as well, because we find that unless you have an early onset of dementia, as we get older, it's one of the biggest risk factors for dementia. So when we talk about aging and sleep, there are certain things that happens as we get older. So for example, you may have a prostate problem. You wake up more often. You may have a smaller bladder. You may have more likelihood of having infections. You may have diabetes. You may be somebody who has sleep apnea. So dementia in of itself does have certain things that come with it that affect sleep-wake cycle, including a change in your circadian rhythm. So you're probably sleeping more during the day because there's not much to do, less of brain stimulation and activity. So you probably sleep in and then you're wide awake at night. But it could also be that you have conditions associated with dementia itself that are very specifically affecting sleep. So you may have restless leg syndrome. You may have conditions wherein you're more likely to be sensitive to noises. Maybe you are hard of hearing and you probably don't hear the alarm going off, so you sleep in. So it could be simple things as a consequence of deficits because of aging that make it seem like you're having quote unquote dementia, and it affects your sleep pattern. So there's a lot of study now saying that your hearing has a profound impact on cognition. Some people estimate it as being a 30% impact on your sleep. Some people say cognition is significantly affected because you don't necessarily hear very well because you don't register information. So when we talk about does dementia itself affect sleep patterns, we need to look at aging itself. We need to look at hearing impairment, visual impairments, sensory modalities that are affected that could be playing a part as well. So it's not just pure dementia all the time.
So as I mentioned, you mentioned restless leg syndrome. Are there other common sleep disturbances in people that are living with a diagnosis of dementia? And what are they and how can they be managed?
Yeah, so you get very fragmented sleep. So it's often confusing when we use words like fragmented. What does that mean? It's quite simple, really. You know, if you were to go to bed and then you woke up once, maybe twice, maybe 3 times, does that constitute poor quality sleep? Or is it that you've been in bed throughout and you wake up and you don't feel fresh? You have to understand it within the context of the individual itself. What is the frame of reference? Was this an individual who was a truck driver their whole life, and the engine noise, the white noise, actually gave them calmness in their mind? Because we now know that ADHD has an impact, and ADHD doesn't start at the age of 65. It's been something you're born with. So there are certain conditions that happen even before you develop dementia that's part of who you are that was contributing to your sleep problems. So when you look at people with dementia specifically, you're talking about things like restless leg syndrome. We know that low iron levels, ferritin, can affect restless legs. We know that. So could it be that you have malabsorption? Maybe you're having cognitive impairment, you're not having good nutrition. Maybe your meals are skipping a few of the important micronutrients that you need. You don't have time for meal prep. Maybe you forgot how to do meal prep. Maybe you haven't told people that you're struggling because you don't know. So when you talk about other specific sleep disorders in of itself is poorly understood. We know what insomnia is. We know intermittent insomnia, and we know early morning awakening or the terminal insomnia. But there are many factors in itself that contribute to each of them. So for example, if I have difficulty in falling asleep because my mind is busy, I have clinical depression. Is it specific to dementia? Not necessarily. Can you see it in dementia? For sure. What about things like sleep apnea? Yeah, you can have issues with sleep apnea. Obstructive sleep apnea is very well known, but then you also have other conditions like central sleep apnea. You need to be evaluated thoroughly. What about over-the-counter medications because I think this is what I need because I can't fall asleep? Well, if the cause is something different, you need to get that addressed. If the dementia itself, the type of dementia you have, so for example, if you have Alzheimer's dementia, you're more likely to have a specific predilection to certain types of sleep issues. We know that 25 to 50% of people can have sleep problems. What about people with frontotemporal dementia? Why frontotemporal? Well, they have REM sleep behavior disorders. They wake up at night, they're moving around, they're not lying down, they feel the dream is real. Because normally during REM sleep, your muscles should be paralyzed. You don't move around, you don't think of acting out on your dreams because you're asleep, your muscles are paralyzed. But if you so happen to have something like a Lewy body dementia and you're having a component of REM sleep behavior disorder, that's integral to the dementia itself. Does that make sense? So you have those conditions, and then you have generalized things that happen because of aging and cognitive deficits, rather than just the dementia itself.
So it could be the dementia specifically, or it could be dementia and a wealth of other things that are contributing.
Correct.
Right. So with that in mind, are there any activities or strategies that a care partner could provide to help support their partner who is living with a dementia and is having, some difficulties with sleep?
Yeah, that's a big one. That's a very big one. And that's just not isolated to people with dementia. It can be with people who have chronic pain, people who have repeated bouts of constipation, right? So you haven't gone, you don't feel right, you won't be able to sleep. It's going to be hard. That doesn't mean that your dementia is causing a sleep problem. Second thing, if you don't have proper hydration and you're thirsty, maybe you have a long-standing history of migraine. Maybe your pillow is bad. You have neck pain. You can't sleep. You have spasms. Maybe you have a very small bladder. You need to wake up very often to go to the washroom, but then you have this habit of drinking a big glass of water just because before you go to bed. You are going to wake up to use the thing for sure. So if the caregiver, for example, says, you know what, no fluids after this time so that you do get proper sleep. Before that, you can have as much as you want. Maybe we add more vegetables to your diet. We cut down on just focusing on red meat. Maybe we add fruits into it as well. So maybe a slice of apple, maybe you have celery, maybe you have things that have a higher content of fiber, but also things that may contain higher amounts of tryptophan, because we know tryptophan gets converted to serotonin. So maybe have some pistachios, have bananas. There's your fruit. Maybe a milkshake, because milk contains tryptophan, maybe a warm glass of milk. Avocados contain it. So if you look at caregivers looking at things that can improve the quality of sleep, because we all know the importance of routine, you're looking at the bed they sleep in. You're looking at the environmental stimuli. So for example, the temperature, a lot of the times if you go to seniors' homes, the temperature is cranked up and it's really warm. When you walk in, it really hits you. The problem with that is, as you get into the evening time and you want to sleep, the temperature may be a bit too high for people to fall asleep. You need it to be slightly on the cooler side. So if you're looking at keeping the temperature at about 18, 19, you're more likely to want to snuggle under the blanket and get some sleep because it's going to keep you warm. And you dread getting out of bed because you think, oh my God, it's a bit cold outside, let me sleep in the bed. So there are things that can help you prevent yourself from waking up at the smallest thing. When you can continue your urine, you can hold your bladder better, your bowel movements are better, you're having things that help you with your sleep. Your pillow is good, it's been changed, the mattress is okay, you have a good warm blanket, and the temperature is regulated. So if the caregiver can look into all these different aspects without burdening themselves, it improves their quality of sleep as well.
Right. It's the whole oxygen mask in the airplane goes on you before it goes to your children, sort of the same ideology as well. So if your partner is sleeping better, then hopefully as a caregiver or a care partner, you're also going to be sleeping better as well.
Yeah, that is correct.
Perfect. Now, I know sometimes people will resort to perhaps an alcoholic beverage to help maybe decompress and have a glass of wine before dinner, hoping that might help with some sleep later on. Can you speak to the impact of alcohol or caffeine alternatively in improving or maybe not improving the quality of sleep for someone living with a dementia?
Mm-hmm. Sleep is one of those things that you only realize its value when you don't have it. It's like being pain-free. You don't realize how nice it is not to have a headache, a back pain, a knee problem, an elbow problem, a shoulder problem. But you realize that only when you have a problem. So many a times we abuse our system. So for example, there's a research paper that came, if I remember right, it was in the BMJ Open a number of years ago, which said alcohol is bad for the brain from cradle to grave. And why it was emphasizing that is because it affects all organ systems. But if you're talking about sleep, it can help you fall asleep, but you won't stay asleep. And over a period of time, it affects your ability to actually have good quality sleep. Caffeine, on the other hand, which basically blocks adenosine, we know that caffeine in some studies say, well, it's good for dementia. Well, it's not good for dementia because if it was, then a lot of people who lived in South America drinking a lot of coffee for centuries would not have had cognitive impairment. Or for that matter, people who drink 4 to 5 cups of coffee should not have cognitive impairment. Well, it's not true. Because if you look at sleep itself, there is a particular system in the brain that we know now in the body that's called the glymphatic system, not lymphatic, glymph. There's a G before the L. And so if you have a habit of lying on your tummy, apparently the clearance of amyloid slows down. So you sleep on your right lateral position. So you're looking at us helping improve sleep just by position, number one. Number two, we spoke about temperature and diet. Now you're looking at adding something into your system, which was never a normal part of it, right? Some people argue, well, you have fermented yogurt. Yes, you do, but it's not alcohol. So if you look at the impact alcohol has on the brain, it's profound. It's a severe depressant. And earlier we spoke about how maybe the person is depressed and not falling asleep. Well, there you go. If you don't get good quality sleep, your mind is not going to feel rested. You're going to feel exhausted. You're more likely to feel sad, preoccupied, worried, and you're constantly going to think about not falling asleep, which is the worst thing you can do for sleep. So we look at the new energy drinks that are coming in, right? People drink very high amounts of caffeinated beverages. So on the one hand, you have the normal coffee. Have a cup of coffee in the morning, no problem. Then there are people who argue, well, I don't have coffee, doc. I have tea, which probably has a higher amount of caffeine. Then they ask you, what about decaf? Well, for sure, you can have decaf as well. But it goes back to the fact that often our knowledge bases are very limited to the research that's available, not the research that's needed. So when we talk about caffeine and we talk about the impact of caffeine on sleep, there are many other breakdown products within coffee when it's roasted, when things like that happen, that change the constitution of caffeine. So if you're looking at adding things onto your system that you think could affect you, you don't start just because of the onset of sleep problem. You start way before, recognizing maybe a cup is all I need. I don't need more. If I'm going to socialize, maybe I should have hot water, right? And many people are doing that now. They actually just sip hot water. Why? Because number one, no caffeine. Number two, it's a hot beverage. It's warm. It's good for you. Have a sore throat. It's good for the throat anyway. Not boiling water, but obviously warm water. But also you're part of the social milieu. So don't feel like you're missing out just because you don't have alcohol, that you're not having caffeine. You're still part of it. So skip it. We know that it affects the brain, both of them, but if you have to have it, you have it in very limited quantities, not on a daily basis. And if it's going to be Christmas or something like that, and you just want to be part of having a good meal, maybe you can have an occasional drink, but it cannot be the one that you use for sleep because it doesn't really help with sleep on the long run.
I'm going to switch gears a little bit and ask you to talk about whether if we see changes in sleep patterns, whether that's indicative of changes in the progression of someone's dementia. Do the two go hand in hand, or are they more separate entities?
Yeah, excellent question. This is a very, very important question for a number of reasons. Number one, can we predict the progression of cognitive deficits by way of reflecting on their sleep patterns? It could be a multitude of things, including pain that's progressively getting worse. It could be sleep apnea that has not been treated. It could be restless legs that we haven't even bothered to look into. Or it could just be clinical depression. It could be somebody who's actually having clinical depression, repeated bouts of UTI, there's some infection somewhere that's affecting the patient, or just medications. If you look at the number of medications that are coming out and you look at the side effect list, the benefits, the role is probably 2 or 3 lines, But if you look at the side effects, it's like a textbook. It's a massive textbook. So many medications we conventionally give to people who have dementia could be contributing to a sleep problem. So if you take common used medications like Aricept, they can affect sleep. If you look at many patients who have ADHD and have been on medications for years, ADHD medications can affect sleep as well. What about antidepressants? Yes, they can. What about cancer medications? Many of these medications can have an impact on your sleep, but it's just that we're not aware of it. So, for example, you come with dementia, you are on Aricept, you're a bit restless and agitated, another medication has been added, you have Prozac. The first thing you need to look at is whether the medications are contributing to the sleep problem before we infer that there could be a sleep change that reflects underlying dementia. So are there changes in specific sleep-related issues as dementia progresses? It's not very distinct. It is not as if you go from mild dementia to severe dementia and then there's a sudden transition. There isn't. What really does happen is the brain capacity decreases to engage during the day. The individual is not as engaged. They have many more episodes of falling asleep, less likelihood of falling asleep at night. So if you look at the day-night patterns and see whether the person is actually engaged during the day and seeing whether there is activity to keep the brain active, that would be a bigger indicator of whether the illness is progressing or not, rather than just a sleep issue. Okay, so there are many patients who sleep too much. Is that good for the brain? No, it's not. Excessive sleep actually is terrible for the brain. So then you can argue, what about teenagers? They sleep in. That's good for them. Teenage brain is growing up, and when they're active, they're very active. But it should not be a persistent pattern where someone is sleeping 12, 13 hours a day. That's counterintuitive. It's not helpful at all. In fact, when you try to sleep in after a night of being busy, you find sometimes you wake up with a headache. People want to catch up on sleep. You sleep in on a Saturday, you wake up with a headache because excessive sleep doesn't really help. So the sleep patterns that you're seeing, yes, with dementia, people sometimes do tend to sleep more, less arousable during the daytime because they fall asleep, they have these micro naps. Does that indicate that dementia is progressing? Possibly. Is that a specific indicator? No. But you can get those changes and keep the patients pre-morbid functioning. Before the dementia started, what was it like with them? Were they short sleepers? Were they night owls? Were they people who sat and had coffee at night, chatted with their friends, shift workers? Find out what their patterns were and then see if it's related to the dementia.
That's fascinating. So yeah, I think so often we just assume that if there's a change is a relation to the disease progressing. But you're saying, in fact, it could be a multitude of different things, and it could in fact be too much sleep, which is keeping them up at night and causing them to have some nighttime exploring or restlessness and those sorts of things that we would initially just say, oh, that's just part of the dementia diagnosis.
Absolutely. So, for example, if you go to some homes, you find that the patient was agitated, they've given something to sleep during the day. What do you think they're going to do at night? So we often have to keep that in context. And it's very important for loved ones to often ask, what do they do during the daytime? If they're at home, see that they're engaged. It doesn't have to be anything very complicated. You can sit outside and watch the kids play. You can watch the cars go by. You can listen to some kind of a podcast that you're interested in, listen to an audiobook. But keeping people engaged is paramount. And then you can infer into sleep changes during dementia.
So in those cases, I mean, ideally, that sounds, a wonderful opportunity to take advantage of those levels of engagement, but that's not always the case and always the reality for certain individuals, given their environments and time, etc. So in the case of situations where there are those nighttime exploring episodes or that restlessness, do you have any effective techniques or strategies to mitigate some of that?
So when someone does not sleep at night, irrespective of whether you have dementia or you don't, one of the things that you need to look into is, number one, is there something you can do with the patient at that point in time or with yourself when you don't get sleep at night? Cognitive therapy has made significant changes in the way we address sleep issues by, number one, looking into how you stop ruminations, stop worrying about stuff that happened during the day, because you're not going to problem solve. A lot of people go into bed waiting for sleep to come. That's not how it works. You go into bed once sleep has come, once you're feeling tired, once you're exhausted. A lot of us just go to bed waiting for sleep to come. And then you're thinking, what did Jillian say yesterday? Yeah, why did she say that? I wonder. Your sleep is gone because now you're sitting and problem solving. What you need to do is go sit in a chair, take some boring magazine, some boring book, whatever. But you need to know that you're doing that because you want to bring sleep. So when you look at strategies, the strategies work from a very early age to a very old age, with or without dementia. With dementia, if it's wandering, there's really no treatment for wandering per se. But if the person is wandering after they have gotten up, it's likely that they would have slept a lot during the day. So now you need to let them burn some calories. So if it's within a home, many of the staff will allow the patient, you don't jump and give them medication. What they do is they allow the patient to walk a bit. They get a bit tired, then take them back to bed. Maybe they need to use the washroom. Let them go to the washroom and come back. Maybe they're hungry. It's not always that the food that is served is the food that you like. It's not home food, right? Maybe you didn't eat well that night. You're feeling a bit hungry. Have biscuit, have a glass of milk. Milk contains tryptophan. So you can do things to help while the person is awake that can help facilitate going back to sleep, but also you're addressing why they're awake. Okay, so you can try the milk thing, you can try the cookie thing, you're trying the wandering thing, getting them to walk around, let them use the washroom. Maybe it's pain. If it is pain, give them something for pain. If it is to do with an uncomfortable position, it's too warm, you need to reset the thermostat. Sometimes it's hard. Maybe take off that thick blanket, right? Maybe the patient slept in bed, it's wet. Change the wet. So there are simple things that you can do to actually change these things. The other thing is, if the person, for example, and I've used the example of a truck driver, maybe if it was a shift worker, they are going to be awake at 4 o'clock. So you need to stop forcing them to sleep because they cannot do that. Their whole life as a nurse, they were awake doing a night shift. Maybe you need to recalibrate that with them. So the strategies we use have to keep in mind what's causing the sleep problem, what could be contributing to the sleep problem, and what's maintaining the sleep problem.
Very interesting. And really, I'm hearing from you the impact of personhood, really going back to the individual as a human, as a person, what they did, their habits, their sleep, or their work, and all of those things that contributes to who they are and how it impacts their daily living on a regular basis.
Correct.
Excellent. So you've spoken about medications, other comorbidities, et cetera, having an impact on sleep. Can you talk to me about how sleep issues with dementia diagnosis should be discussed with healthcare professionals? So if you're concerned, all of a sudden you've introduced a new medication, as you mentioned, or you have diabetes, or you have ADHD, and how do we talk to our physicians and our geriatric psychiatrists and nurse practitioners about sleep? What are the best ways to go about doing that?
Excellent. Very nice. I'm glad you mentioned that. And the reason I'm saying that is because, number one, the job of your healthcare provider is to help explain those things. The mistake we make as patients is we don't go in prepared. You need to make a list of things that you're worried about before you go see your healthcare practitioners. And what you need to do is keep a small book with you whenever you go in so that you can write stuff down. It's hard to remember all these things. It's impossible. So what you go in is you go in with a question saying, these are the different things I'm having, these are the problems I'm having. But if you don't prepare for it when you go there, you'll be tongue-tied. You just have no idea what you're going to be asking. You will forget and something else comes in. Oh, by the way, your blood work is abnormal. You've forgotten all your questions. So how do you ask it? Number one, feel comfortable. As physicians, there's nothing we love more than people to get better. That's our job. That's what we're paid to do, right? It's important for us to build good rapport with the people who provide our healthcare. Very important. And it's vice versa as well. So when you come in with an issue that you're concerned or worried about, for you, it has to be a priority list because everybody is hard-pressed for time as well. So you would have your top priority questions and questions where you can say, doctor, you know what? If it's okay with you, this is not really the most important question I have, but it's been bothering me for a while. Can I ask you this question? You want to bring that into the fore. You also want to ask, when you start medications, could this affect me 10, 15, 20 years down the line? So for example, you're on ADHD medication, you were diagnosed in your 60s, you've always had ADHD, your partner has left you, you've lost your job, your kids don't like you. Yes, I've started an ADHD. I'm focused now. I can get things done. I'm not angry with people, but I can't sleep. You need to ask your healthcare provider. Ask your physician, look, medication is working miracles for me. I wish I'd taken this 50 years ago, but I can't sleep. What do I do? Can I take something else in its place, or can you switch the medication for me? It's important for you to come up with these questions so that you not just have an answer, you feel confident when you go back home that you're not sitting and thinking, oh my God, I missed this. Oh my God, I didn't ask that. Because one of the things the brain does is come up with these things when you are in bed. When you ask questions, also make sure you bring in all the medications you've taken, over the counter and previous medications. Why this is important is many medications are being sold, quote unquote, as being miraculous medications. Oh, you have vitamin B6? I think you should take it. Please don't go by those things. There are many people who like to talk about the incredible role of A, B, C, and D. It's not true. There may be some truth, but it's not true by and large. And I'll tell you why. There was a time when a particular treatment was found to be very effective for autism. Okay? And it was effective because that particular child had a deficiency in that state. So it was going to work for that kid, whatever you did. It was going to work for that kid. But that didn't mean it's going to work for everybody. So when you come in and say you were told by my friend, Anne, who lives down the corridor, told me, you know what, I need to be taking zinc and magnesium oxide because it works magic. Well, it did work for Anne. It probably won't work for you because you have normal levels. Do I need to be taking it? No. Why don't you try these other things like what, doctor? Well, number one, your dog seems to want to go and pee at 2 o'clock in the morning. Maybe retrain the dog. So you want to look at talking to your doctor about things that are medically related, but also associated with your condition that is contributing to poor sleep.
So again, going back to the person, going back to their lifestyle and who they are, their habits, as well as any medications. And as you noted, that would include any sort of vitamin supplementation or things like that, because people don't always necessarily associate that with them as a medication. But
Correct.
It's important to talk about.
Correct. Absolutely correct. And even the foods that we eat have a lot of preservatives now. You need to look into whether these things are contributing to sleep problems. So there are medications that can drop your blood sugar. Okay. And you're thinking, oh my God, I think I have diabetes. And you know what? Maybe you do. Maybe you do. You have a strong family history. Maybe you do. But why don't we look at the things that could be contributing to it? Go back to the medications. Go back and look into what side effects are there. And you'll be surprised how many medications can do weird things to our mind and body that you don't need to be referred to specialists. Waste hours of your time going through this investigation, that investigation, if the cause is so simple. Why waste money and time?
So it's important to have those conversations on a regular basis with your physician or healthcare provider and note any changes either way.
And the pharmacist. Yeah, they're very helpful. And I find some of the pharmacists I've dealt with very, very kind, take a lot of time with the patient. So if you don't have time, it's always important. Either you tell the patient, please talk to Jeff, he's a pharmacist here or there. Call up the pharmacist and just tell them, look, I had this patient come in with me. Could you please advise them? They're really worried about this. Building that network is our job. But for the patients to feel that they don't need to be hesitant, they need to be confident about it. So we empower patients by telling them, don't hesitate, please ask.
That's great advice. Well, you've provided us, all of the listeners, with a wealth of information to think about. Before we close, do you have any final words of advice or thoughts to share?
I do. Don't take relationships for granted. Don't take the relationship you have with your sleep or your body for granted. Whatever you do that damages your body now, you'll pay the price down the road. So if you have good quality sleep, make sure you don't experiment with doing things that's going to affect your sleep. Make sure you check before you do anything. Don't cause pain, because pain is one of the things that will disturb your sleep, your quality of life. Make sure you eat healthy. Lots of things are being advertised as this is good, that is good, very high in sugar. Avoid it. Cut down on sugars. Cut down on caffeine. Eat healthy food. Don't have very oily food before you go to bed. Skip alcohol if you can. If you must have a glass of alcohol with your meal, have it earlier in the day so that it doesn't cause acidity. You don't have reflux. You don't have all those difficulties. But make sure you plan it carefully. There's no greater joy than good health. There's no better thing in life than good sleep.
Mhm. Excellent advice. We have to leave it there. Unfortunately, I feel like I could talk to you for another hour, but we will leave it there for now. Thank you so much for sharing your time and expertise with us today, Dr. Amanullah. I'm so very appreciative.
Absolutely. Thank you.
This Dementia Dialogue episode is released under a partnership of the Alzheimer's Society of Ontario and the Centre for Education and Research on Aging and Health at Lakehead University. The Alzheimer's Society is excited to take on a leadership role in producing and marketing our podcasts to strengthen the voice of people with lived experience of dementia. Please continue to follow us on Facebook. Our web address remains dementiadialogue.ca. We invite you to share your feedback on this episode with us. Please visit our website, dementiadialogue.ca, and click on About and scroll down to find the link to the listener survey. Your feedback helps us as we plan for upcoming episodes. If you wish to receive the survey by email, please send your request to dementiadialogue@alzon.ca.